Ranney, Dean of the Yale School of Public Health, to officially open our event.
Thank you. Hi, everybody. It's so good to see you. I will keep this short and sweet because I want to get to the main attraction, which is Dr. Hacker. It is my true honor and privilege to welcome my colleague and friend, Dr. Karen Hacker, to join us for our first Leaders in Public Health series of the year. For those of you that are new students, I know many of you are faculty or returning students, but for those of you that are new students, this is a series that we started last year to try to bring in folks who have had real world leadership experience in public health, both to share their own career trajectories, but also to give us a chance to learn a little bit about some of those very difficult on the ground decisions, and as well as about kind of the vision of where the field of public health is going. So today, having Dr. Hacker help us open up the series this year is just tremendously meaningful to me personally. Dr. Hacker is the director of the CDC's National Center for Chronic Disease Prevention and Health Promotion, where she oversees more than 1,000 staff dedicated to preventing chronic disease and promoting health across the lifespan. Since her appointment, she's overseen the development of community health worker and social determinant of health accelerator plan initiatives. She also has overseen a broad portfolio ranging from maternal mortality to school health, obesity prevention, smoking policies, as well as touching on many of the other leading chronic or non-communicable diseases out there. Prior to this role, Dr. Hacker served as the director of the Allegheny County Health Department in Pennsylvania for 6 years, and has also held leadership roles in health systems, including the Cambridge Health Alliance in Massachusetts. She's an expert in community-based participatory research and has published extensively on this topic. Now, I do love to feature folks who have a connection to this university, and Dr. Hacker is amongst them. Her BA is from Yale, her MD from Northwestern University School of Medicine, and her MPH with honors from BU's School of Public Health. I've gotten to know Karen personally over the past few years through a women's leadership group that we've both been part of, and have been beyond impressed with her vision, her management acumen, but most of all with her dedication to improving the health of all. So Dr. Hacker, welcome. Please join me up here, and I look forward to talking to you today. So I'm going to have us chat kind of in a fireside chat for about 30 minutes or so, and then we'll open it up to all of you for questions. For those who are on Zoom, we'll pay attention to your questions as well in the chat. But to start us off, Karen, I would love to ask you a question that I ask of all of our visitors. You've had tremendous successes over your career, but a career in public health wasn't necessarily always the thing that you thought you were going to do. Can you tell me a little bit about how you got interested in public health and then how you transitioned into public service?
Sure, I guess. It's been a long haul. So I was always, I'm a physician, and I was always very interested in primary care and in the public sector. And I did my residency at Boston Public, it was the
Boston City back then, yeah.
City, right, which is now called Boston Medical Center. And at that point, I was really interested in working in the community. I didn't really know what public health was per se. And it wasn't really until later in my career when I was actually developing a school-based health center and working in community to really do the community organizing. I had a lot of friends, by the way, at Yale. I don't know if anybody knows about Dwight Hall. Yes. Okay. I spent a lot of time at Dwight Hall. And got a lot of my friends were community organizers. And so really was using a lot of those strategies to help build this school-based health center. And then as part of another move back to Boston, realized, well, I probably need to learn a little bit about epidemiology and some of those other things. But in particular, I was interested in healthcare financing. Mm-hmm. And I think I figured at some point I might end up like a hospital CEO or something like that. And so I ended up doing my MPH then as sort of mid-career, in part because I was doing work with managed care organizations trying to get funding for school-based health centers, and I could not speak the language at all. And I really felt like the only way I'm going to learn how to understand this and be able to negotiate at the table is to actually get this MPH. So that's when I actually got my master's in public health. So I was sort of working in public health without really creating a name for it per se. And then I ended up working in public health, particularly in Boston at the Health Commission there, and sort of the rest is history. But I did a tour through academia at Harvard and through the Cambridge Health Alliance, which is a Harvard teaching hospital. And I will say, and I told Megan this earlier, I'm not a big fan of academia. It wasn't really my thing. Kept migrating back into the public sector. I always say you sort of figure out which poison you like best, because every sector will have its own politics, and you sort of have to figure out which one you can really exist in. And for me, I understood the public sector. I figured out how to get things done despite bureaucracy. And I liked sort of the can-do attitude. I sort of felt like, well, let's sort of make this good government. And that was, I think, what's migrated me into this. And so I had never worked at the state level, only at the local level, and which is really where my heart is. And I think at this point in my career, coming to the federal level has been a really interesting experience, because I was the kind of, as a health department director, I would like spend a lot of my evenings out, going to a lot of meetings, getting yelled at a lot, doing that kind of thing. But I really enjoyed being in places where I would hear what people were thinking and gathering that information and really synthesizing it to understand sort of what the critical steps were that we were trying to accomplish.
So what did bring you into federal service, into your role as director of the National Center at the CDC?
Well, as many things in my life, I have not always been clearly directed in terms of this job, this job, this job, this job. I had been at Allegheny County for about 6 years, and I, through my career, have really enjoyed building things. And I like coming into an organization when it needs a lot of work. When I went to the Allegheny County Health Department, which for anyone here who's from Pennsylvania or Pittsburgh, that's the major city in Allegheny County. It was kind of a disaster. I mean, seriously, it was a disaster. There was like one deputy and 400 people, and they were giving back over $1 million to the state every year, just to give you a couple of things. And
Wait, giving back $1 million that had been appropriated to them, but they didn't spend. Not a good look in public health, right? Like, we need all the money we can get. Yeah.
So I spent 6 years there really essentially renovating the department. And I said, I wasn't expecting to have to bring hammer and nails. I think there was a lot of work, but I wasn't expecting that. And got it accredited, if anybody knows about public health accreditation. And then at around 6 years, which seems for me to often be my sort of time frame, I was sort of going like, what do I want to do next? And I didn't really know. Because of the places that I've sort of been involved with, it's sort of like, well, here's the option. Do you want to go back to academia?
Mm-hmm.
Do you want to do government? Do you want to do managed care, which pays a lot? My husband always said, why don't you want to do managed care? And I was thinking it would be great to run a big city health department, but I will tell you, those are hard jobs to get. And especially if you don't know people, if you're not involved with the folks who are in those elected positions.
Political appointment. You got to have the connections. Yeah.
Have those connections, or actually be from there and have sort of migrated into those scenarios. And so a friend of mine mentioned this job to me, and I'm like, oh, they're probably never going to want someone like me. I've never even been at a state level. So I was quite surprised when I got the note saying, we're pushing your resume on to be interviewed. And the whole thing was sort of, once it takes the CDC, if anyone wants to work at CDC, just be prepared. It will take a long time to get the job. So it was over the course of about 8 months before I actually was finally given the job.
That makes academia look quick. And tell us a little bit about your role as center director. What do you see as kind of your primary goal or function? You and I have talked about how the CDC, like academia, is decentralized in many ways, right? The CDC director has some power, the center directors have some power, but really it's about those kind of line item appropriations to those 1,000 folks or 40-ish programs under you. Talk to us a little bit about what you see your mission and vision for your center being, and how you help to get that to happen, despite or maybe because of the unique structure that CDC has.
So my center is one of the larger centers. We have a $1.4 billion budget. Yes, you heard me right. And we give out $800 million a year in grants. So We're both a very large department and a very large grant giving organization. I often say when I go out, mostly people come up and want to know what the next NOFO is going to look like so that they can get funded. Honestly, that's kind of their biggest interest in what we do. When I came in, what was very apparent to me is that my divisions, and I had at the time 8, I now have 9 divisions, they're very independent. And the way that the money flows, it comes directly to them for very specific areas. So for example, if you're in diabetes, they have a particular line focused on chronic kidney disease. Yes, they can't use that for anything else. I do not actually have a budget of my own. So part of what I was really interested in was how am I going to forge a team out of these diseases? To give you a little sense, I've learned a lot in the last 5 years. I think when I first came in there, I thought, oh, I just want to blow this whole thing up and reconstruct it. I want to have a big department of prevention and not, maybe have chronic disease entities over here, and that will never work. Well, why will it never work? Well, because we get our money from Congress, and a lot of that is driven by special interest groups. We are friends with many of these special interest groups, but the truth of it is you have all of the American Heart Association, American Lung Association, American Cancer Association, American Medical Association, and on and on and on. They're all advocating for their particular areas. And as it turns out in chronic disease, there are very specific advocacy groups for very specific diseases like lupus and epilepsy and those kinds of things. And they are going to their elected officials and pushing to get resources. So for us, our center has really grown up around these diseases. So there's a lot of folks who are really interested in diabetes. There are a lot of folks who are really interested in cancer and heart disease. And there's a lot of folks, it turns out, who are really interested in tobacco and making sure that people reduce their tobacco utilization. And so those groups, they're the ones who are going to the halls of Congress and really pushing for us to get increased dollars. So I've been there 5 years and our center has grown every single year. But oftentimes it's in drips and drabs across 42 separate line items. And tomorrow, if someone goes to Congress, I tell you a little story recently.
Please.
I believe Usher was at Congress talking about his son who has diabetes type 1. And now the Republicans actually have a bill to support money for us at CDC for diabetes type 1. Diabetes type 1 is not preventable. So it's a little bit of what do we do with the money when we get it? And usually it's not enough to turn around and give it out to states. So often it's about education or about surveillance of disease entities. But as a result of that, I do have a whole variety of individual small diseases with maybe $2 million associated with them, such as interstitial cystitis and arthritis and things like that.
Interesting.
And then you'll see a disease like Alzheimer's over time grow and grow and grow and grow. And now that we have seen, since when I first started, there was no dollars for arthritis, for Alzheimer's at all.
Wow.
And now we have over $30 million.
Wow. And just for those who are students in the audience and kind of want to understand a little more. So you get this budget, it's divided across these 42 different programs. And you said you spend more than half of it in grants out, and then the rest you spend internally. Can you give folks a little sense about what you spend, how you think about those buckets of money, what types of things you spend it on, what types of things do you make grants for, what type of work do you do internally, and how you make those decisions?
All right, and keep me on track because I'll go.
I will, I promise. Yeah.
So
and then I'll have a related question after.
In most cases, we really want to push the money out so that states, by and large, sometimes communities, but mostly states, have resources to focus on chronic disease. We are pretty much the largest funder of any chronic disease programming at the state public health level. Okay, in some cases, we're the only funder for those types of things. And when you look at the amount states get, it's honestly not very much. So, while it sounds like a lot of money, when you start dividing it up among states and territories and tribes, it's not that much per se. Individual grants range from like $250,000 maybe to $1 million at most.
Which doesn't pay for a lot of
Right.
staff or
Doesn't take a lot of staff.
programming.
I'd say
Yeah.
mostly what we end up paying for is people.
Yeah.
Because we don't generally pay for infrastructure or buildings or anything like that. What we do in terms of CDC staff ourselves is a lot of epi research and surveillance.
Yay,
Probably
chronic disease epi.
most important thing, is the surveillance, right? We have two of my favorite surveillance systems in the world. We have the behavioral risk factor surveillance system, and we have the youth risk behavior surveillance
True
system.
story. My MPH thesis was 2 papers, and one of them was based off of Briffus. So I'm very grateful. I
Well,
wouldn't be sitting here without it.
What you call
Yeah.
BRFS, whatever you call it. These two systems have been in place for a very long time. The youth risk behavior surveillance system, which I just got back because we brought the Division of Adolescent and School Health back together. There's a portion of it that had been in another center and portion in my center, and now it's one division. That is the youth risk behavior is the only self-report survey of youth behaviors across this country. So it's really, really important. And my specialty is in adolescent medicine. So for me personally, this was like a really important piece of information. And we use those systems as well as a whole variety of other surveillance systems to then do analysis about what's working, about we don't do, unlike NIH, we don't do randomized control design, things like that. But what we're doing is really trying to identify evidence-based practices so that we can, in fact, transition those to these states and locals to actually be able to implement in the field. So one, for example, is the Diabetes Prevention Program, which has been around for a while and got Medicare to fund it and is reimbursable. And so in our diabetes national program, that's one of the things that goes out there. Now, we do have a prevention research center, which I know you know well, and some of you may have been involved in, and I know you didn't get funded this last
We're still keeping hope. We had a good score, but you guys just ran out of money. So
but
yeah.
This is one of the ways that we actually get some of the research done that we're never going to be able to do ourselves. And a lot of that is in the intervention and implementation side of the world, right? So you can get a wonderful evidence-based practice and then try to put it in the field and it doesn't work. And why does it not work? And who does it work for? What language should it be translated into? All of those questions in the implementation realm, we can't do all that work. So we really look to the PRCs to help us with that. And then I think there are, in many cases, contracts that go out to the field to look at a particular scope of work. Say we want to do, right now we have a project on modeling social determinants of health from health outcomes as well as from a financial perspective. And that went out as a contract. And you hear about a lot of these big organizations. In this case, it's RTI, which you may have heard of, but you hear about a lot of these organizations that get those contracts, are very used to living on those contracts, have a very strong public health staffing, and they're currently involved in a 3-year project to do that kind of work. The other place I think that universities often get involved is in evaluation of these national programs. I am really pushing these days for rapid evaluation. I have a very hard time when we have a program and the evaluation comes in long after the next iteration of the grant goes out. And really, it's very interesting to me as we try to push the rapid evaluation construct, how many of our own people are really
uncomfortable with it. Yeah.
Thank you. I was going to say something, but are really basically finding themselves, but this is the way we've always done this. And we have our strategies and we know what we're using, and I'm really pushing them. First of all, I have to go to Congress and I have to make a case for these programs. And they don't want to hear, well, I won't know for 5 years. That does not go over well. They want to know, what have you done in this year? Sometimes it's just numbers. How many community health workers did you hire in the first year? What are the projects and how many people have they served? So I'm really trying, I think, back to your prior question, to sort of get my center to be more action oriented and to communicate the work that it's doing more effectively, so that, I think in chronic disease, because it takes a long time, people are very apt to say, oh, what have you done? I mean, I actually had a congressman recently say, well, diabetes has been going up since the 1970s. So what have you done with all that
Oh
money?
my God.
That's the kind of stuff we get. And this issue of return on investment, really
Mhm.
focusing on that, how do we demonstrate that prevention actually works? This is so much of what we do in our center, whether it's in the social determinants realm or health equity, but really how to make a case for that, particularly given that we are seeing, as I'm sure you all are aware of, this just enormous tsunami of elderly people. I will account myself as part of that, who are just using the healthcare system, and it becomes very difficult to convince government that they're going to have to somehow right that ship and focus more of their attention on prevention. So that's a lot of where my head is at. I do a lot of external work, as you can imagine, to push these messages. But if I can't get that
Data back.
back
Mhm.
from whether it's from our partners doing the prevention research centers and then feeding that information back to us, or whether it's the work that we do internally, it is absolutely critical.
And I know you and I, when we were chatting a few weeks ago, one of the things that you said you loved about these external engagements is starting to learn about some of the emerging research in the field, because the folks at the CDC can only do so much. So one of the ways that we can play a role is, of course, applying for your grants, but also making sure that we do the work to highlight emerging issues or emerging solutions, and then trying to get them in front of either Dr. Hacker and her staff, or in front of our congressional representatives and senators, who are the ones that actually make the decision around appropriations. I think one of the things that I've learned from talking to her is what a difference, not necessarily lobbying, but kind of advocacy, representation, storytelling, and then backing up those stories with data makes in terms of the ability to create those funding streams that support work on the national level, but also on the state and local level. And so I'm really grateful for your space in that. Relatedly, one of the things that I think that you do tremendously well is to kind of see the future. We were talking about kind of, you've taken training in foresight, not in a crystal ball kind of way, but in a kind of what the emerging problems are. And so I'd love for you to share with the audience a little about kind of the public health crises that you're looking ahead to. What do you think the big priorities of your center are going to be over the next 3 to 5 years, should you stick in the director role or not, but for that long?
So part of this is trying to read the political tea leaves. And I do consider myself, having spent so much time in government, to have a pretty good, astute awareness of kind of what's happening. But as I was saying to you, Megan, sometimes it's just waking up in the morning, looking at your feed and trying to see what's coming through and trying to understand, is this going to stick or not? Is this something that the public's going to be aware of?
Climate change and health, big thing that we're spending a lot of time thinking about right now. 5 years was not really on the radar, as an example.
I know.
Yeah.
On the flip side of that, though, it's what's going to be bought? What can I actually say? What is the next administration going to support? Because they do make it clear that certain things are, not going to be happening under that administration. So I do think that there is a lot of, from my perspective, and we were talking about this earlier, there's a lot going on in chronic disease with new medications, and the GLP-1s are like an enormous disruptor. And I am really,
For those, the GLP-1s are like Ozempic and
Yeah.
Wegovy, right? Yeah, just making sure.
and not only are they obesity related, but they're diabetes related, and now they're heart disease related. And I won't be surprised if they're related to addictions pretty soon. In fact, we're already hearing about them being prescribed for that as well.
Mm.
So what does that mean for prevention and for lifestyle and all these things that we in public health have held so dear? And I don't want to see public health get axed out because, oh, now we have a treatment modality. So part of what we're really talking a lot about right now is how do we continue to really push the prevention message, push the lifestyle message, and see these new medications as adjunct, but not the only thing. And I think that we have to, personally, I feel like a lot of times public health is always on the end of the spectrum, and they're not particularly engaged or flexible. And they're sort of living in their own little world. And I feel that that's really a problem. So for me, a lot of this is about how do we move into these realms. I've spent a lot of the last 4 years, 5 years, focusing on social determinants of health, which is really my passion. And that area was something that I felt like I brought in with me from the field. I think it's still incredibly focused in the field, but now at the federal level, we're kind of getting told, don't use that term anymore.
What term are you getting told to use instead?
They don't really like social because that sounds like socialism. And they don't like determinants because that sounds like it's fatalistic. Some people are using drivers.
Mhm.
I'm just sort of using non-medical conditions
Mm,
and focusing more on the actual issue, like food
food deserts
security
or, yeah.
or connections to clinical care or policies that support no smoking, things like
Mhm.
that.
Built environment. Yeah.
And that tends to go over a little bit better and talking about, and that's why we're really doing this modeling work to really be able to say, well, we know if a community gets together and does this, there's a result.
Hmm.
So I feel like the other part of this is a sort of a reinvigoration of some of the work that Tom Frieden did when he was at the center and actually at the agency to really focus on that return of investment. I also am a big proponent of the relationship between healthcare
And public health.
this has been something that we in public health have been dealing with really since the initiation of public health, right?
CEA Winslow, way back when in 1918. Yeah.
And we sort of go through fits and starts. And every time there's a sort of an iteration, and you guys are too young to remember the triple aim probably, but during the triple aim, there was this focus on population health. And isn't that what public health did?
Yeah.
You know, and then suddenly we didn't do it anymore. And now the clinical delivery system had all these population health people that it was hiring. I feel like the same thing, we are very at risk for the same thing happening around social determinants because now the clinical delivery system is being required by the Centers for Medicaid and Medicare to screen individuals for social needs. And they have now interpreted that as addressing social determinants. I personally feel like social determinants are a lot bigger than what happens in the doctor's office. And honestly, if you refer a person for housing and there's no housing, I'm not quite sure how you're changing the social
Yeah.
determinants.
So one of the places that I've been kind of languaging around this is kind of saying that I actually, for healthcare workers, it's not fair to ask them to be all things to all people. And of course, they should be aware of what the social drivers of health are that their patients are experiencing, but we can't ask them to also be a shelter and a domestic violence advocate and a food bank. And so it's on us to set up the systems that allow doctors and nurses to do their jobs more effectively. But and I think part of it, and I'm hearing you say this just to say out loud, is that to a certain extent, we have to get over the idea that we as public health are the redheaded stepchild of the system, right? We have tremendous value that we bring to the table. And in fact, some would argue that having a great public health system, again, makes healthcare's job easier and more effective. And you've spent some time thinking about that communication aspect. Would love to hear your thoughts about kind of how you communicate about the value, both of chronic disease prevention and treatment, but also the larger field of public health, because you spend a lot of time in the rooms with politicos trying to get them to buy in to the value of the very clear value of what we do, but in language that will resonate with them. So tell me a little about how, yeah.
So first of all, a lot of times I am the only public health voice at the table.
Yeah, which is great
And
that you're
everyone else
there.
is
Yeah.
But I think one big example of that is that I worked with my colleagues, particularly around this social needs screening,
Mhm.
and we actually got them to change their language. So they are now using health-related social needs. And
That's
I thank them
awesome.
for that because it was a lot of work, but seems like a little thing. But for them to actually distinguish between health-related social needs and social determinants as the bigger policy, systems, environmental issues
Mhm.
was, like I said, a big win. And then that gives us the opportunity in public health to demonstrate that we're working in that bigger area. Now, the problem, of course, is that our public health system is dearly underfunded.
Yeah.
And one cannot say that every jurisdiction has a really strong public health department that those clinical systems can effectively work with. And that's, I think, an incredible challenge for us. Similarly, at states, you know, the amount of money that states put into public health varies
Tremendously.
enormously,
Yeah.
right? And so then what you hear is people in academic institutions and clinical systems saying, well, I tried working with them, but that was like a disaster.
Mhm. Mhm.
And to me, that erosion of this, our public health infrastructure is incredibly challenging. I've really been pushing our public health colleagues at the state and local level to recognize what's going on in the clinical system around the social needs and social determinants. Because if you're not going to be at that table, you will be left out.
That's right. And there's actually funding behind the screenings because of CMS. There's actually funding to do it if you're within the healthcare system. That's a great point. Related thing, one of the things that I've always admired you for is your ability to not just do the research, but also to be a great manager, to create teams that are effective. We have a lot of folks out here that are either managing teams of their own as faculty or as staff, or as students maybe have aspirations to being leaders and to running teams of their own. I wonder if you have any pearls for folks about effective team leadership and management, because you've said you've managed to turn around a couple of teams and clearly run something very successful and impactful at CDC.
So first of all, I really like management, and I
That's a
will
good
not tell you
start.
that a lot of people in the medical world and in the public health world necessarily are really enjoying management or are
Yeah.
particularly good at it. And I feel like at the basis of that is that team experience. And so identifying, the right people who want to be part of your team and who you think can contribute in multiple ways. And then at the same time that I tend to be more of a participatory leader, if you're going to label it in any way, shape, or form. I used to say the reason is I don't want to be the only one making the decision. So I'm not completely responsible. But I do think that once you can get a team together, you have this unbelievable sort of energy that feeds on itself. And I'm a believer that success breeds success. And I've seen this experience, so the money starts to flow, and then the more money and the more success, the more money. It's sort of, it is a self-fulfilling prophecy. And I take it back to, I was on, I think this is what really convinced me. So when I was a resident, you had to do a rotation on the cancer ward. And during the time I was on the cancer ward, we had this incredibly fun team. And no one died that entire month. And that experience for me sort of was emblematic of a really
high functioning team. Yeah.
It makes you want to, because you see these things kind of connect to one another. And then
you've got each other's backs, and and you have fun with it. That's great. Well, I want to open things up for folks in the audience to have questions. I could keep going. I have a bunch more, but I want you all to have a chance to ask questions. Feel free to ask about specific disease entities, about Dr. Hacker's experience at the CDC. Xiaomei. And if you don't mind introducing yourself, I know that many of you are meeting her over the course of the day, but.
Yes, thank you. I was going to say one thing about me is my hearing.
Thank you for
I
taking
appreciate it.
take time to share your insights with all of us. I'm glad you brought up the GLP-1s. There is this kind of trend. People see it as a magical drug, a cure-it-all for obesity, diabetes, and everything related to the cardiovascular diseases. But we don't have any long-term data on the outcomes. Whatever that we observe in clinical trials does not translate naturally to the general population. So I wonder what you think about that and what we can do as a research community to potentially address that.
So this is basically what our conversation was this morning. First of all, I do not think that this is going to stop the obesity epidemic. And it's certainly, from what we're seeing, as you know, a good portion of people who take these medicines do not continue with them, or if they get off of them, regain their weight, right? But, in this country, we always like the magic pill. So I think the direction we're going is to really focus our attention on how do we connect lifestyle change to the GLP-1s. And I was giving an example. I just got back from Australia. And I was so fascinated because in Australia, they're using the GLP-1 as an adjunct to nutrition and physical activity support. And they're using the lowest dose possible. So rather than doing what we seem to be doing here, which is to up until you get side effects, they're doing the opposite. They're saying, no, we're going to keep you on a low dose, which, by the way, is not going to be that expensive. Like you may be able to afford $150 a month. With nutrition visits and physical activity, and they're having sustainable success. And they're thinking they're going to keep people on these meds probably for a pretty long time, but at such a low dose that it's not going to give them all these horrible side effects. To me, that was just one of those like aha moments, right? Because it's such a different approach. But it also brings up this whole question of like, for us in public health, and because you reacted to this, in the obesity world, and this is, world we're deeply involved in, we've talked almost 100% about the prevention aspects of it. And we haven't focused really on the treatment of obesity, right? And let's face it, if you're 400 pounds, if you're, 400 pounds overweight, reducing sugar sweetened beverages isn't going to do a lot for you, right? And I don't know about you, but I had tons of patients at age 15, 16 who were so big that there was very little I could offer them. With that said, these give us a new tool. So what's our space from public health in the secondary prevention space? Because obesity is a condition, it's a disease, a chronic disease. And we really haven't thought about treatment of obesity in the same way. So I feel like we're just at the beginning of, first of all, you're right, there's so little known about this. It's taken off like wildfire, but we don't know who it works for. We don't know how long to take it. We don't know how much to give. We don't know what it looks like in primary care to connect lifestyle with it. What can be done? Is this something like depression when we've given people protocols and procedures to handle depression in primary care? Or is it something that's more like HIV where we really want specialty clinics to take care of this? I got nothing. I can't hand anybody clarity about what really works. I was saying earlier that it would be great, for example, to do a trial that demonstrates the difference of GLP-1s with lifestyle versus without, to really get this, so to speak, in the drinking water. I feel like if we really have to step up, because I do think that the exactly what you just said, which is that if we stand back, this is going to basically take off as the treatment of choice. We're going to see the issues and disparities because not everyone's going to have access to it. But we're also, I think, going to see a lot of real negative complications from these drugs. And at the same time, we're going to just see weight regain because ultimately it's like a diet, right? I mean, the bad word diet, as you said, but that's basically what it is while you're on it. So been thinking a lot about this space, and I feel like we're at the ground level and we really need to have a really comprehensive approach to how we're looking at the research in this area.
Lots of fun study ideas there. Mayor.
Hi. Good afternoon, Dr. Hacker. My name is Mayur Desai. I'm a faculty member in chronic disease epi. I started my career as an EIS officer in a chronic disease focused position.
Say what EIS is for the students who may not know.
It's the
Epidemiology Intelligence.
Epidemic Intelligence Service 2-year fellowship program for training in applied public health and field epidemiology and outbreak response. I had a question. I've seen more and more students, especially in chronic disease epidemiology, who are considering positions in consulting and other kinds of things that previously were more healthcare management and policy-oriented students, but seeing more students in epidemiology. And I think there are, excellent opportunities. I was wondering how you might make the case for public service and in particular federal service, where 8 years at a time, your career might be under an administration with whose values you don't agree with, whose priorities you don't agree with. You're very much influenced in your position by the priorities of the administration, by the CDC director, by a center director. I was just wondering how, when you think about your career and 8 years at a time potentially are going to be potentially challenging and what it is. So your position as center director is very different than the person who's working at the agency. You come and go, but people try to make it their career. So I was just wondering if you could say something about working in that type of environment in the case for federal service.
So I would just say that I don't think federal service is much different than government service at any level. I worked for an elected official in Allegheny County, happened to have a 12-year run of it, but was reelected every 4 years. And every 4 years, we had another, election campaign. And I've worked for mayors. So it's the same kind of issues. I used to say that public health is really political health in a lot of ways. But for me personally, I feel like that's where you can make change. And there are these windows of opportunity that come along. The mayor of Philadelphia, I think I was at a meeting once and he said something like, windows of opportunity open up and our challenge is to jump through them and to make the most change that we can in the time that's allotted to us and recognize that the pendulum will swing back. It's the nature of the beast. But hopefully some of those changes have become sustainable. And that's really how I've seen my service at the government level, whether it was at the county level or whether it's at the federal level, is what is it that I can do to really embed those changes so that they aren't as vulnerable at that higher level, but that they're really going to become the change that happens in the field. And to me, that's what's been unique about working in the public sector. And you can tell I like the public sector. I've enjoyed it. It is not for everyone, I will say. And I think if people, when you're in the private sector, you have different flexibilities, but you're also very vulnerable, right? Tomorrow, a new CEO comes in and wipes everybody clean. I got calls from 2 people I know recently where that kind of thing has happened. And really, they didn't do anything wrong. They just weren't part of that individual's entourage. So I think the dynamics are different. And, my friends who work in the clinical sector and epidemiology, I will tell you, they are working really, really, really hard. So,
which we're thankful
they
for.
might be getting money. They might be getting a lot of money, but it is
Work-life balance does not exist. Yeah. I'm going to give time to, do we have a
We
Zoom?
have 2 questions online.
If we do one Zoom question, then back to the room, and our students in particular, feel free to raise your hand. So
I'll read the shorter one for timing. It says, you spoke briefly about closer integration between public health and health systems. Can you share any early success stories in this effort?
So I started getting interested in this, more than 15 years ago, in particular, around this construct of population health. And at the time, I was working in Cambridge, Massachusetts. I was the acting public health director. And I brought in 3 different health systems to help us work on a particular issue that we were focused on. I think at that point, I'm going to try to remember back, I think this was early on in the substance use and abuse issue around opioids. And they were able to sort of come together in a way to think about what they could offer. I think at the time we had something called Dawn data. I think
Dawn still
which was
exists. Yeah.
data coming out of emergency rooms, and we were able to pool that data. So from me as a public health person, I needed to work with all of those different groups. Similarly, when I was in Pennsylvania, we were focusing actually on oral health care. And I brought together 4 different managed care organizations who provided me with some data to be able to do some really strong analysis about where we had gaps across the system. I think that there are real challenges because of that difference between the jurisdiction, and I'm looking at you, but it's looking up there, I think, the jurisdiction and the healthcare systems that surround that jurisdiction. I used to think, oh, wouldn't it be great if you were just one public health department and one healthcare delivery system, and you could really figure out how to forge those alliances. But I think those are the unique situations and not the norm. And for many healthcare systems, they're covering not just multiple jurisdictions in one state, but they're covering multiple states. And so that challenge I brought up earlier, which is they've got, 150 different healthcare departments, public health departments that they need to work with. And how can you convince them that it's worthwhile to have that relationship?
For those that are interested in learning more about that, I would also urge you to look up the Common Health Coalition, which our School of Public Health was one of the founding members of, started by Dave Chokshi, who was the last commissioner of health in New York City. We have some really interesting initiatives that are taking place, that some of which we're part of, but there's opportunities for more for those who are interested in that overlap. Maybe one more question. Well, we may get two, but we'll certainly have time for one more from the audience. Susan.
Hi, thank you so much, Dr. Hacker. Susan Nappian with the Office of Public Health Practice here at the School of Public Health, and I actually was the first intern at the Yale Griffin Prevention Research Center when I was a student
Right.
here in CDE. You talked a lot about skills that you've needed to have: diplomacy, systems thinking, collaboration. For those of us, and I'm hoping that our students will kind of go into this area of pracademia, where they bridge practice
I
with
like
academia.
that, Susan.
For academia. I know I find myself working a lot with the state health department and local health departments. What advice could you give our students about what skills they might develop or what experiences to help them sort of bridge and collaborate and really elevate and amplify the evaluation and implementation science that they'll need to support our local and state health?
So you've named a lot of them. I mean, to me, this is the same lessons that I learned in working with communities are the same strategies that I use in working with any other sector, right? And that has to do with, number one, probably you better be humble. And I think sometimes for academics, they go in, they got their doctorate, their PhD and and they walk in and there's a perspective that they know more than the people that they are working with, whether they are state public health officials or whether they are members of, whatever street that they happen to live on. So I think going in with an incredibly humble perspective that these are your partners and they have a lot to teach you. In doing community-based participatory research, every time I worked with community, they would blow up one of my preconceived notions. Like I would think I understood what was going on, and then they would point out to me, no, you forgot all about this. And I'd be like, oh man, I didn't even think about that. Having the curiosity to really get at that, I think is a big piece of that. And recognizing that the perspective that whatever they are, maybe they're environmentalists, maybe they're engineers, but the perspective that they bring to the table has value. And that your challenge, I think, is being able to interpret it in such a way that you can communicate it. And so I feel like a lot of, I often will say that the magic happens at the intersection. That's where the fun is. And the question is, can you actually bridge that with your understanding? And that, I think it comes with that communication, but also what are you offering ultimately to them? What is the benefit of what you're bringing to the table? They're not there just to serve you, right? They're there to get some. If they think that they're going to get something, believe me, they will be more than happy to have you there, much more than you ever anticipated. And I feel like that's the kind of skill set we don't really talk about that much, this bridging capacity and how to teach it. And how to teach collaboration. I hired somebody in my department to actually create a little collaboration hub.
Oh,
And we were thinking about, we actually had some ability to fund someone to get a PhD. And I said, oh, I'd really like to fund somebody in collaboration science, which I don't know if it actually exists.
it's team science.
Anyway,
Yeah.
we were looking around and we couldn't really find any place where there was a discipline like that. We would have to pull from here and here and here and here and here to sort of create it. But it just pointed out to me that this area, which I think is so important, it's important for team building, it's important for getting the work done, it's important for moving the agenda, important for collective action, you name it. How do we figure out a way to teach this?
Great. Do we have time for one more, Holly? Yeah, all right. Do we have one more? Oh, Jackson?
Dr. Hacker, my name is Jackson.
Oh,
Can you hear me now?
yeah.
Hi, Dr. Hacker. My name is Jackson Higginbottom, and in addition to my work here at the Prevention Research Center, I also direct a free medical clinic in Oklahoma City, and our patient population is largely undocumented, uninsured, and one issue we are running into is, as always, is access to medications, and especially now, given the role that GLP-1s are being used in treatment for obesity and diabetes. I'm concerned about that access issue. Are there any upcoming initiatives with the CDC to help expand access to GLP-1s or other treatment options like these for these populations?
So just from the perspective that CDC is not involved in expanding access to medication, that would really be CMS and Medicaid and Medicare. But I will also tell you that no one in the federal government is going to be providing medication to undocumented.
Yeah.
It is what it is. So that will continue to be a challenge. And I did in my prior life work a lot with undocumented immigrants. I published on it. I've written a lot about it. I've written a lot about healthcare around the world and what happens with undocumented immigrants because it's dramatically it varies constantly, right? It continues to be a challenge. Right now, though, I will also say that GLP-1s are, the inequities, regardless of whether you're documented or undocumented, are incredibly prevalent.
Sure.
I know that there is interest in Congress in trying to change that. I don't know if it will be successful. These patents are probably going to be good until what? I think it's
I actually don't know.
2040 or something before the price is right. Isn't 2040? Before the prices will actually come down. So I think we're going to have to also come up with strategies. I was very interested in the fact that the Australians were talking about using much lower doses. And part of that was to make them financially accessible. Because, if you say to someone you have to pay $1,500 a month for a drug, but if you say to someone you have to pay $100 a month, you may have better luck with it. So I don't have a lot of positive things to offer on
But this is where us being involved in advocacy and telling our stories and having relationships with our local, either state or federal officials can make a big difference in terms of raising awareness about the challenges with paying for medications. Right, that's how we got the Inflation Reduction Act, which, right, of course, is only for folks. The part of it related to pharmaceutical prices, it's only for folks that are age 65 plus or who are on Medicare, but is going to have a tremendous impact over the next 5 years in terms of bringing down the price of some of the most commonly used medications that existed when the IRA was written. GLP-1s, of course, were not written into that, but we're seeing tremendous drops in costs of insulin, of many of the common blood thinners that we use, and so on and so forth. The 10 most common medications used by the Medicare population. That was because of patient and provider and public health advocacy at the federal as well as at the local level, and it would be lovely to see that expanded so that it's true not just for folks that are on government insurance, but also for folks that are on private insurance or who are, and of course there are programs for people that are uninsured in general, but they're difficult to access often. So advocacy makes a difference. With that, I think I'm going to close this up. Dr. Hacker, thank you for coming back to your alma mater, and I hope that you get to go back and visit Davenport and see where you spent your bright college years. But we really are grateful for you coming to visit, sharing some of your perspective and experiences in leadership, in public service, and most of all, as an advocate for the health of all. I'm excited to see folks' careers change perhaps and take a little bit of a different direction thanks to this discussion. But most of all, grateful for your service to the country and to the folks that live in it. So with that, you can't leave Yale without a little swag bag. So a little thank you for you. Whoops. There you go. Thank you. Thank you, my friend. Thanks for coming.